auscultation of the cardiovascular system. So first is so these are the good exam. See, the following anatomical pictures will aid you in understanding the principles of cardiac auscultation. So here, so this is, see, this is the right atrium. This is the tricuspid wall, superior vena cava, aorta, pulmonary artery. Here is a pulmonic wall, right ventricle, left ventricle, aortic wall, mitral wall. So this white one, mitral wall, left atrium, and this is the aorta. Okay. And so become comfortable with your stethoscope and engage the diaphragm of your stethoscope and place it firmly over the second right intercostal space. So the second right intercostal space is the region of the aortic valve. So which is the region of the aortic valve? The region of the aortic valve is the second right intercostal space. Then move it to the other side of the sternum. So move it to the other side of the sternum and listen in the second left intercostal space. So the second listen in the second left intercostal space. So this is the location of the pulmonic valve. So this is the pulmonic area. So move down along the sternum and listen over the along the sternum. You are moving down and listening over the fourth intercostal space, the region of the tricuspid area. So this is the region of the tricuspid area. And finally position the diaphragm over the fourth intercostal space, left mid-clavicular line. So this is a mid-clavicular line. Here is the mitral area. So these locations are rough approximations and are generally determined by visual estimation. They are just rough approximations. So in each area, you have to listen specifically for S1 and S2. So each area you have to listen for S1, S2. Okay. S1 will be loudest over the left fourth intercostal space. So where is S1 loudest? So this is loudest over the left fourth intercostal space, mitral or tricuspid valve areas, and S2 is loudest along the second right and left intercostal spaces, that is aortopulmonic regions. S1 is loudest at the left fourth intercostal space, that is mitral and tricuspid valve area, and S2 along the second right and left intercostal spaces, aortic and pulmonic valve regions. Note that the time between S1 and S2 is shorter than between S2 and S1. So S1, S2, S1, no? So the time between S1 and S2, no? So this is shorter than between S2 and S1. So this should help you to decide which sound is produced by the closure of the mitral or tricuspid and which by the aortic or pulmonary valves, and therefore when systole and diastole occur. So compare the relative intensities of S1 and S2 in these different areas. So the time between S1 and S2 is shorter than between S2 and S1. So this should help you to decide which sound is produced by the closure of the mitral or tricuspid and which by the aortic or pulmonic valves, and therefore when systole and diastole should occur. So compare the relative intensities of S1 and S2 in these different areas. So in younger patients, you should also be able to detect physiological splitting of S2. So this splitting of S2, no? So this you should be able to detect in younger patients. So this S2, it is made up of two components. So what are the two components of S2? A2, P2. Okay, so A2 is aortic and pulmonic valve closure. So what younger patients, you should be able to detect physiological splitting of S2. So on inspiration, when you are taking a deep inspiration, so what is happening? Venous return to the heart is augmented. You are taking a deep inspiration. So what is happening? Venous return to the heart is augmented and pulmonary valve closure is delayed. So because of the increased venous return to the heart, what will happen is the pulmonary valve closure is delayed, allowing you to hear first A2 and then P2. So on inspiration, you have taken a deep inspiration. So what is happening? Venous return to the heart is increased. So because of the increased venous return to the heart, what is happening? The pulmonary closure is delayed, allowing you to hear first A2 and then P2. On expiration, the two sounds occur closer together and are detected as single S2. So on inspiration, what will happen? So P2 P2 closure is delayed. So on expiration, the two sounds occur closer together and are detected as single S2. So ask the patient to take a deep breath and hold it. So giving you a little bit more time to identify this phenomenon. So that is why you tell the patient to take a deep breath and hold it. So if the patient takes a deep breath and holds it, no, it will give you a bit more time to identify this phenomenon. So the two components of S1, mitral and tricuspid valve closure, occur so close together that splitting is not appreciated. If you have to appreciate splitting, it is only S2, but it is not S1. So never comment any splitting in on S1 because the two components of S1 and S2 occur so close together and splitting is not appreciated. Okay, so this is the normal cardiac cycle. So this is the systole, this is S1 and S2. Okay, S1 S2. Okay, this is shorter, no, like this. S1 S2 is shorter and S2 S1 gap, it is diastole. Okay, and during expiration, both of them are single sounds. Uh, so expiration, they are single sounds. During inspiration, no. So A2 is closing earlier and then we are getting this P2. Okay, so A2 and then P2 because P2 is close later. So you might find it helpful to tap out S1 and S2 with your fingers as you listen, accentuating the location of systole and diastole and lending a visual component to this exercise. So while most clinicians, you may find it helpful to tap out S1 and S2 with your fingers as you listen, uh, accentuating the location of systole and diastole and lending a visual component to this exercise. So while most clinicians begin auscultation in the aortic area and then move across the precordium, it may actually make more sense to begin laterally in the mitral area and then progress towards the right and up as this follows the direction of blood flow. So we can start. So it actually makes more sense if you begin laterally, that is in the mitral area, and then progress towards the right and up as this follows the direction of blood flow. Mitral area, tricuspid area, pulmonary area, and aortic area. So try both ways and see which feels more comfortable. So listen for extra hard sounds. So these are called as gallops. So while present in normal subjects up to the ages of 20 to 30, they represent pathology in older patients. So in normal subjects up to age of 20 to 30, they are normal, but they represent pathology in older patients. And S3 is most commonly associated with left ventricular failure. So whenever there is a left ventricular failure, you also have to look for S3. Okay, so it is caused by blood from the left atrium. So blood from the left atrium, it is slamming into already over filled ventricle during early diastolic filling. So why is S3 occurring? It's associated with left ventricular failure, and it's caused by blood from the left atrium slamming into already overfilled ventricle during early diastolic filling. So the S4, no, it is a sound created by blood trying to enter a stiff non-compliant left ventricle during atrial contraction. S4 means it's by blood trying to, here what happened in S4, what is happening, the left ventricle is, it is stiff and non-compliant left ventricle during atrial contraction. S4 is due to stiff non-compliant left ventricle. S3 means left ventricular failure. So left atrium, blood is from the left atrium, it's already slamming into overfilled ventricle during early diastolic filling. So when do we get this S4? Most frequently with left ventricular hypertrophy, that is a result of long-standing hypertension. So if you are suspecting congestive heart failure, look for S3. S4 means left ventricular hypertrophy, long-standing hypertension. So either sound can be detected by gently laying the bell of the stethoscope over the apex of the left ventricle. So if you have to listen for S3 and S4, no, what you have to place? You have to place the bell of the stethoscope. So they are particularly mentioning the bell at the apex of the left ventricle, that is roughly at the fourth intercostal space, mid clavicular line, and listening for low pitched. So because they are low pitched extra sounds that either follow S2 or precedes S1, that is an S4. So S3 is preceding S2, S1, S2, S3, and S4 is before the S1. So these are the S4 before the S1, S3 after S2, S1, S2, S3 in a particular line. S4 is before the so okay, so that is about the sounds. So these sounds are quite soft, so it may take a while before you're able to detect them. So positioning the patient on their left side while you listen may improve the yield of this exam. So if you have to look for these sounds, you have to position the patient on their left side while you listen. So this will improve the yield of this exam. So the presence of both an S3 and S4 simultaneously, if you hear S3 and S4 simultaneously, so this is referred to as summation gallop. S3 and S4 simultaneously heard, so this is called as summation gallop. So then coming to murmurs, so that will be next.